Hello there. I am Dr. Caroline Hodson. I am a psychologist here at Nationwide Children's Hospital. And in my work, I work on our inpatient psychiatric units, working with kids and teenagers who have recently tried to kill themselves or had a significant mental health crisis. And so I'm excited to have the opportunity to present to you today about managing suicidal crises and responding to more significant mental health challenges, especially in children who've been directly impacted by war and armed conflict. So a few things we'll cover today. One is just in general, reviewing the impact of war on suicide and self-harm. Some of that might feel straightforward or obvious, but a lot of the research actually presents a pretty interesting and complex picture of how this does affect youth. We're going to go through the basics of screening for suicide risk. How do we identify kids who might be at risk of trying to kill themselves? We'll talk about specific interventions for achieving immediate safety in the aftermath of, sharing suicidal thoughts or screening positive. We'll talk a little bit about non-suicidal self-injury, so a different but related problem of youth who are struggling with cutting or burning themselves intentionally, and how do we manage that as mental health providers. And then we're going to spend the bulk of our time on specific interventions for these challenges. So what are things that we can be doing in therapy beyond that initial safety plan to make sure that we're continuing to treat the problems that are showing up in these ways, specifically with kids who have the unique challenge of being affected by war. So first we'll start with what does the picture look like for suicide in those affected by war, and especially for youth. The picture is actually, as I mentioned, pretty complicated. So Durkheim, famous sociologist, an early suicide researcher, suggested that suicide rates might be lower in nations that are currently experiencing war. His theory for this initially was, when a country is at war, people experience a lot of collective patriotism. They feel extra connected to their fellow man, to their country. And so they might feel less alienated and less likely to want to kill themselves. However, the contemporary evidence is not super clear on that picture. We'll talk about some different explanations as to why, but one study, for example, from Northern Ireland came out and showed that suicide rates did actually decrease a decent amount during the Troubles period in Ireland, where there was a lot of active bombing, active conflict. But then as the region transitioned to a period of peace, there was actually an increase in observed suicide rates. One of the paths for that is there seems to be a little bit of this transition that corresponds where individuals are going from feeling like I just have to survive day to day. I'm really focused on making sure my basic needs are met, that I'm not dying. Once they are at a period of stability and peace, that almost puts them at more risk as they kind of come to terms with all that they've lost. When you have a moment to take a breath and realize that your city is destroyed or that your family members are gone, that starts to hit differently and contribute to greater suicide risk as you start to recognize and come to terms with all that's happened. Understandably, just experiencing all of the difficulties associated with war and armed conflict can create a post-traumatic stress response where being exposed directly to those events is likely to contribute to flashbacks, difficulty sleeping, hypervigilance, and just difficulty staying settled or feeling safe in an environment. Again, understandably, if you've literally not been safe in an environment for quite some time. And then an additional thing that we see with youth in particular that is related to the idea of war is this fact that parental loss, whether it's loss by a parent dying by suicide, a parent dying due to war, or just displacement. So a parent is displaced overseas, they're on refugee status in another nation, parental divorce, any amount of kind of forced separation from a parental figure is considered a pretty significant risk factor for suicide when it occurs during youth. Just again, this disconnection and this pain and loss of such an essential relationship as part of development. And again, understandably, that is more common and more frequent when a nation is at war. Parents are often involved in that, and that just creates some additional challenges for those youth even after the war resolves. So what about Ukraine in particular? Again, another great example of some kind of mixed results, but that corresponds with some of the things we've already discussed. So in the immediate aftermath of Russia invading, the Crimea region, affected regions actually experienced a pretty significant decrease in death by suicide. Again, there's sort of bigger fish to fry, bigger concerns on the table. And so folks aren't thinking about kind of deeper existential questions. They're focused on day-to-day survival. But then over time, some of what we've seen is that teen girls in regions affected by armed conflict in Ukraine were actually significantly more likely, almost twice as likely to report suicide attempts, suicidal thoughts, and non-suicidal self-harm compared to the same subpopulation, so again, teen girls in a region of Ukraine that was not affected by this conflict. And so what we're seeing is, as a little more time settles, as this becomes essentially what day-to-day life looks like, and there's not that immediate shock and aftermath, that begins to create some greater mental health challenges. Another study showed that direct exposure to bombing in particular created significant increases in suicidal thoughts and specifically feelings of helplessness, which is another risk factor. Feeling like at any moment you can walk outside and your daily peace could be substantially disturbed, or an entire building could eventually vaporize. That understandably puts people on edge and really challenges their sense of stability and safety. And then again, the same study before with the teen girls, one of the other findings was the more war-related traumatic events any of these girls experienced led to additional increases in suicidal thoughts and self-harm behaviors. So it wasn't a black and white, were you affected or were you not affected? There was what we call a dose-response relationship, where the more traumatic events they had experienced, they had additional risk of engaging in these behaviors, which for us suggests there's a causative relationship, that this is actually actively contributing to the problem. So I want to take a step back too and zoom out and think about how does suicide look different for teenagers in general? So armed conflict aside, some of the things that we know about suicidal behavior in teenagers are really helpful for knowing how to effectively intervene when we're trying to support them and stop these behaviors from occurring. One thing that we know, again, to our advantage, is that a lot of teenage suicide attempts are less likely to be lethal and more likely to be impulsive. That, again, works to our favor because it gives us opportunities to intervene after a suicide attempt that doesn't end in death. This is not because teenagers don't actually want to die. It's usually because when they're impulsive, they're just reaching for the first method available, and it might not necessarily be the method most likely to kill them. Also, just because teenagers don't have as much ability to problem solve, intentionally plan this out, they're not necessarily thinking about the different relative lethality of different methods. Again, this is a positive thing, and it works to our advantage in terms of our ability to intervene. Another thing that we know about teenagers that's really important is that they're more susceptible to this phenomenon called social contagion. And so it doesn't mean that suicidal behavior is, dangerous to talk about or dangerous to provide education or screening on, but it does mean that when a teen is exposed to another peer who dies by suicide, we know that contributes to additional risk for them. This typically happens by not making them aware for the first time that they could kill themselves, but by presenting a model of how someone, quote unquote, successfully solved their problem. And so if a teenager who they knew personally was really struggling and now appears to no longer be struggling, that image is really sticky in a teen's brain. And what we know from the data is sometimes we'll see in, for example, a high school, what they call suicide clusters, where a few teenagers will either kill themselves or try to kill themselves in quick succession. And so based off of that, we know it's really important to intervene early with teenagers and to provide a lot of education up front so that we're not waiting for the worst to happen, because that creates additional kind of snowballing problems for us. So that is our overview of suicidal behavior in teenagers, particularly those affected by war. And so I want to spend some time just talking about best practices for finding kids who might be at risk, finding kids who are having these thoughts of suicide, who likely haven't shared this with any adults yet. So some things that we know based on a lot of research that's been done over the last 50 years in terms of screening and finding children who are having thoughts about suicide. The first is that, at least in the US, 80% of teens who end up dying by suicide had recently visited a medical doctor. So within the last month or so, they went to either their primary care physician or another medical appointment. And that's compared with only about 20% of them had recent contact with a mental health professional. And so many of these children are not necessarily in ongoing therapy. We wouldn't be able to find them all just by asking local therapists, hey, who seems to really be struggling? These are kids that we have to go out and find in their doctor's offices or in their schools. Another piece of information that we know is that medical patients pretty rarely just volunteer information about suicidal thoughts without being directly asked. Again, this makes sense if you think of the purpose of a medical visit. If I'm there for a broken ankle, I'm not going to just bring up that I'm also having thoughts about hurting or killing myself. And so it's not something that we can rely on asking, do you have any other concerns? Are there other things on your mind? Because especially teenagers are not likely to naturally make that connection, or they might be pretty hesitant to just open up about this to a new person. But another thing that we know is that asking youth directly about suicide has been shown to be safe in many, many studies, because this is a common concern that comes up from parents, from providers. We don't want to essentially put an idea in their head. We're afraid that if we say, hey, have you ever thought about killing yourself? They'll say, no, but that's a great idea. And what we know from the research is that's not the case. Kids who have thought about suicide are often relieved by the opportunity that they didn't have to break the ice. They had a path to share, yes, actually, I've really been struggling in this way. And those who haven't thought about suicide are not, startled, harmed, inspired. They tend to just react with, no, why would I think about doing that? Which, again, is usually positive information that signals that they haven't had those thoughts yet. But again, especially for a setting that hasn't implemented this yet, we don't want to create greater problems. And what we tend to find, actually, is that this prevents a lot of further problems because we give kids opportunities to seek the help that they actually need. So what does screening for suicide actually look like? Unfortunately, we can't do a blood test or other kind of biological lab-based tests. And so it does involve a lot of direct questions. So usually we're not doing super lengthy, detailed assessments with every single kid because many children have never had any of these thoughts, even though the rate of depressive symptoms is increasing, both in the US and globally. And again, especially in response to significant traumatic events like armed conflict. But we know that plenty of patients will not need a full half-hour detailed assessment. This should not create a significant burden on a school or a healthcare system. But we do really encourage first, when we're asking about, thoughts of suicide, we're using that specific language. We don't want to be confusing, ask about, hey, have you ever thought of the end of your life generally? That can be confusing and can create some unhelpful answers. So we want to say directly, have you ever thought about killing yourself? Even when we ask, have you thought about hurting yourself? Again, we'll talk later in the presentation about non-suicidal self-injury, but that is a different experience than specifically a desire to die. And some kids might not even signal that they're thinking about killing themselves if they think the method they've thought of wouldn't hurt. They might think, no, I haven't thought about hurting myself, I just want to die. So again, we want to ask directly about not just their thoughts that they're having currently, thoughts that they've had recently, but we also want to ask specifically about any past actions, any times they've previously tried to hurt or kill themselves. Again, we'll talk about this in just a few moments, but This is important information when we think about the overall risk of engaging in future suicidal behavior. We always say the greatest predictor of future behavior is past behavior. And so if a child has tried to kill themselves in the past, even if they're not feeling suicidal today, we're going to need an emergency backup plan because those thoughts can change really quickly. We still believe them, and we want to make sure that we're keeping them safe. In general, those initial questions will tease apart. Most of the kids will not need further questions, and some of the kids will need a few follow-up questions. Those follow-up questions can still be brief. When I complete this in my own practice, this process takes, the extended process takes 5 to 10 minutes total. But the things that we're asking about include asking about the nature of the thoughts, how frequent they are. For some kids, especially if they've been exposed to someone else dying by suicide, these thoughts are what we call intrusive, where they're not daydreaming or thinking about, I want to kill myself. They're having a thought that really disturbs or bothers them, that pops into their head and scares them. That probably isn't as significant as a patient who's thinking about how badly they want to be dead, how badly they want to die. So making sure that we distinguish that. We also talk about passive versus active thoughts of suicide. So kids who say, I think things would just be easier if I could just be dead, or if something would happen to me and I could die, but they're not necessarily thinking of, I want to kill myself. That represents an escalation in how serious the thoughts are. We want to ask about any methods they've thought about or used in the past. Again, this gives us a lot of information in terms of keeping them safe in the future and also knowing how seriously they've thought about this. When I'm working with younger children, sometimes they'll say, yeah, I've thought about I want to jump out of a helicopter and get eaten by a shark. And I am a lot less concerned about that than a patient who says, yeah, I want to shoot myself with the gun that I know is in my father's bedside table. That is a very, very different picture of clinical risk, even if they both fully have a desire to die. And then the last two things we ask about are intent. So are you thinking that you would actually act on these thoughts, or is this something that you just have in the back of your head, you're wrestling with? And then specific plans. So sometimes they think, yes, I would really like to kill myself, but I haven't essentially decided when. Plans are interesting because once someone has had a plan in the past, you can't really forget a plan. And so even if they no longer have intent to die, if they have planned to die in the past, that represents some risk. And additionally, because again, we know with teenagers, many of them are impulsively engaging in these behaviors, they're overwhelmed in a moment, they might skip the step of having a plan. And so we don't want to wait until we get to that stage to say you're at a significant risk, you need some extra support, because many of them will never engage in any planning at all. Other things we know in terms of risk factors for death by suicide. Again, any past behaviors, also things that we call preparatory behaviors. So this could be, I've been keeping a few pills every day in my bedside table. I want to collect enough pills to try and overdose. Or it could be writing goodbye notes, giving away my possessions. Things that signal these are actions that are taking them closer to dying by suicide or showing that they really intend to act on this. And then another risk factor, again, we'll talk about this more, is that non-suicidal self-injury. It is important to distinguish that kids engaging in that are not engaging in smaller, less severe suicide attempts when they cut themselves. But we know that that kind of reduces the biological barrier to causing yourself harm. And so if you're comfortable, familiar with hurting yourself already, that makes it less difficult to cross that threshold and kill yourself. We also consider a pretty big risk factor if they have any access to lethal methods of killing themselves, even if they've never personally thought about using those to kill themselves. So again, patients who have loaded, unsecured guns in their home, that is significantly dangerous, even if they've never thought about killing themselves with a gun, even if they say, no, I would rather not kill myself with a gun. We just know that that's really dangerous, again, because things can change very quickly. And then significant hopelessness and feelings of social isolation are significant concerns for how risky somebody is. Someone who's experiencing a good deal of pain, but in the context of a strong and supportive community, is often much safer than someone experiencing even a little less pain, but in total isolation and loneliness. Those are folks who are a lot more vulnerable because they don't have those support systems to hold them back up and buffer that pain. So the interventions we'll talk about today, so essentially safety planning and other things, we want to initiate this emergency backup plan if there's any suicidal thoughts in the last month especially, any history of suicidal behavior, even if it was 2 years ago. But when I say interventions, I'm usually not talking about psychiatric hospitalization. I think of that as a real last resort, even as someone who personally works in that setting, because it's very expensive, it's very resource intensive, it's not always helpful, and it is often fully unnecessary for someone to maintain safety outside of the hospital. Again, these interventions are an emergency backup plan. Think of this as pulling the fire alarm when we smell smoke. I recognize that this is in English, but wanted to present just an example of a commonly recommended suicide screening pathway. Again, if you're working in a non-mental health setting, like a doctor's office or a school, people tend to really benefit from flowcharts with direct decisions, so they don't feel like they have to use judgment that they don't have to determine whether a child needs additional screening or additional assessment. So thinking of these three paths where plenty of patients will not have any concerns, plenty of patients will need additional assessment and additional little bits of intervention, and some patients will be at immediate imminent risk. So let's talk through some initial safety interventions that you would probably do at your first clinical contact, and then later on we'll transition to what does ongoing intervention look like. So I think of these 4 principles as kind of the key 4 things that I want to address with any patient that I'm concerned about ongoing risk of suicide. First, I want to address any immediate safety needs. So just rule out if they're telling me they've thought about overdosing, if they have taken a handful of pills before the session, that needs to be immediately medically resolved. That takes priority over any other mental health assessment. Also, if there are immediate needs where if I'm sending them home to an environment where there is an unsecured firearm and they know where it is, I want to make sure that before they walk in the door of that house, we have that fully addressed. The next step is what we call limiting access to lethal methods or lethal means. This is typically a really direct conversation with the child's parents or caregivers rather than a conversation with the child directly. This is an example where we would want to be thorough with the parents, but earlier when we talked about giving ideas, there's a difference between asking about suicide and there's a difference between going through a list of every possible method. For someone who is already at risk of suicide, that could be dangerous to essentially suggest alternatives. We'll talk a little more about what that looks like and what we focus on. We do want to explicitly, when we're working with kids and teens, rely on the support of their caregivers. So family members, parents, grandparents, any other adult caregivers who can be recruited to support the child in their recovery. And most importantly, we want to develop a shared safety plan with the child. This is not just a piece of paper. This is not just a checkbox. This is really the core intervention to prevent a later suicidal crisis. So with regard to lethal means, really what we want to prioritize and focus on is removing or reducing access to suicide methods that could be fatal. Globally, the most fatal method of suicide attempts tends to be guns or firearms. And so no matter what, if those are in the home, we are recommending, if we can, remove them from the home temporarily. So can we store them with a friend or a family member while the child is participating in mental health treatment? And we understand that that's not always an option, right? For some families, they're either not able to store the firearm elsewhere or they're not willing to for different reasons, especially around kind of home safety and home security. And so in those situations, we want to reduce access, whether that's locking the firearm in a lockbox, storing the ammunition separately from the firearm if we're able to, and being very intentional about keeping this from the child. Here at Nationwide Children's Hospital, whenever a child discharges from our inpatient psychiatric units, we have, through our local county, funds to provide families with lockboxes because we know how essential that is in terms of reducing their risk. So the two that we really prioritize are, again, firearms and medications, because that's the most common method that children tend to attempt suicide with. And it's also typically a little easier to restrict. I can clearly throw away old medications, lock away prescriptions, and have parents start administering any required medications to the child daily. There are other things that we might involve in lethal means counseling that would be more case by case. I've worked with a family where the child lived on a farm and so had access to a lot of ropes and had specifically had thoughts in the past about using those ropes to hang herself from a specific part of their family barn. And so for them, counseling really looked more like, how do we limit her access to the barn? How do we supervise her when she's doing chores on the farm? And so it wasn't as much about these things, even though we're also checking these boxes just to cover our bases. So most importantly, we want to talk about what is a safety plan. We'll talk a little later on about other roles that the caregivers play. But again, this is a collaborative intervention designed to reduce the risk of acting on suicidal thoughts. Again, if we think about kids and teenagers are probably not at their best when they're acutely overwhelmed, and it would probably be pretty challenging when you're in a crisis to think of from scratch 10 different coping skills you could use to calm down, when really all you're focused on in that moment is making the emotional pain subside. And so I think of safety planning as working with the child. I'm not telling them what to do. I'm getting ideas from them, what has worked for them, what is available to them. But we're really shaping their ability to problem solve in advance. So identifying there will be moments where I'm at risk, I need to recognize my own warning signs, and I need to have a game plan in place so that I don't have to think through it in the moment. Again, the written plan is just the outcome of the actual intervention of developing this together, rather than handing a child a blank piece of paper and saying, you can leave the hospital or the therapy office when you're done with the paper. That has really not been demonstrated to be as effective as spending the time talking through this and making a really strong safety plan. Key components in pretty much any version of the safety plan, I'll show an example on the next slide as well. We want to identify clear warning signs that someone's experiencing elevated risk for suicide. This could be both internal, so I'm noticing that my thoughts are starting to race, or that I'm having more hopeless thoughts, I'm having more thoughts about different ways that I could die. Or it could be external, where I stop going to school, I'm sleeping in a lot, I'm not really responding when my family asks me to come down for dinner. So it might be things that family members can identify for me, and it might also be things that are internal that signal to me I need to do something different. The next step is usually essentially your plan A. So when I notice these warning signs, what are things that I can do to take my mind off of these thoughts, things I can do to calm me down, different strategies to help me relax. So I want to start with those independent strategies, things that I could do if I'm alone in my room, and just notice some of these experiences. Then what I consider to be essentially our plan B is I've tried several of the strategies in plan A, and I'm still seeing these warning signs. I'm still worried that I might get to a point where I want to act on these thoughts. And so once I get to my plan B, that is using my environment. So it might be I go out in the backyard for a change of scenery. It might be I call a friend, have them talk to me about something funny or lighthearted to really take my mind off of it. It might be that I play a card game with my younger brother. Things that essentially turn up the intensity of the distraction factor and really help me soothe and calm down a little differently. Very common with our patients is just going for a drive around the neighborhood. So having, mom just gets in the car and we don't go anywhere in particular. We just spend some time out of the house looking at the road. And then our plan C is essentially we've tried plan A, we've tried plan B, and we know that we're still struggling. So plan C is our emergency response. Who am I going to contact? Who is an adult that I can reach out to for support when I know that I'm still feeling suicidal and the things I'm doing on my own are not working? This could be things like crisis support lines, but it could also just be calling your grandma to come and sit with you while you wait for your mom to get off of work. This could be having a specific plan for what words the child is going to say, because it's not easy to call your mom or your grandma and say, I'm having thoughts of suicide, can you come get me? So it might be literally planning out the words they'll say and having the family plan out how they'll respond so that doesn't, freak the child out or cause additional stress in the future. So again, I wanted to provide just an example of the way that this looks in our healthcare system. So this is essentially our format. We are writing this together. We're putting it in our electronic medical record so that future providers can have access to this too. Whenever a child comes in an emergency, they can ask, hey, do we need to update any of this? Do we need to change this? We really consider the safety plan to be a living document, so it's not something you do once and it either works or doesn't work. It's something that can continue to be modified and adjusted over time. And then again, some strategies for enhancing safety planning, because I think for some people, the paper document is where suicide care kind of starts and ends, and we don't think about all of the practical pieces of how this is going to be used. So first, I like to spend a lot of intentional time with the patient, making sure that I have their buy-in and motivation to use a safety plan. This can feel kind of goofy or cheesy to a teenager to write out a list of things that I can do to make myself feel better. And so really helping them understand our reasoning behind it is preventing a future suicidal crisis. I want to spend some time orienting them to what the plan does and also what it doesn't accomplish. So I have here a picture of a bowling alley, and I know, at least here in the United States, when we go bowling with younger children, we can put what's called bumpers so that the ball doesn't fall into these gutters. I think of the safety plan as bumpers, where it keeps you from dying, but it doesn't get you down the alley. A safety plan is not the treatment for the suicidal thoughts. It's the emergency plan that keeps them from taking you before you're able to get the ongoing treatment. So some patients will say, all I'm doing is distracting myself over and over again, but I still keep ending up in this point. What's the deal? The safety plan's not working. And the truth is, the safety plan is working. We just also need to do other things. We want to spend some intentional time brainstorming skills and really double checking that they will be helpful. Very commonly, teenagers will tell me, I want to listen to music as a coping skill. And then when I ask a little more about what music are we listening to, it is very sad music and music about killing yourself or doing drugs. And often we need to take a step back and say, hey, is that music going to be helpful when you are in a position where you're thinking about killing yourself? Do we maybe want to have a different playlist for those moments? Similarly, again, we want to troubleshoot that plan. So when they say, I'm going to call my friend and we're going to go get ice cream together. That's great. What happens when you're suicidal at 3 in the morning? And so making sure that we have plans for all of those different things that could go wrong or different situations that we know they're likely to experience distress. And then we want to intentionally plan for how they will use and access this plan. So does that mean taping a copy inside their bedroom door? Does this mean having a picture of the strategies on their phone? Does this mean it's on the fridge and the family is reminding them of, hey, it seems like you're really going through some stuff. Do you want to try some of the tools on your plan? There are a variety of different ways. Index cards in one's wallet is another one. But just making sure that we have a plan, because there was a really discouraging study a few years ago that suggested almost 2/3 of patients who leave an inpatient hospitalization never even look at their plan again. And so these plans are only as effective as they are used. So we want to make sure that there is a plan in place to use the plan. So if you are not a mental health provider, if you work in healthcare or work with kids and teenagers, we still recommend, again, this universal screening. So that doesn't mean we have to do full diagnostic assessments of every teenager. We don't have to become counseling facilities and mental health care facilities. But again, we know these kids are not necessarily all coming to us directly to say, I'm having thoughts about suicide, I need to get linked to therapy. if you're working in one of these settings, it's usually encouraged, helpful to have one professional designated for those brief follow-up assessments. Again, someone who's familiar with different ways to ask those questions and feels comfortable and confident deciding whether a patient needs something more intense like hospitalization, and someone who is able to do the safety planning really effectively. This could be a school counselor, it could be a social worker in the doctor's office. It doesn't have to be that every single physician needs to know how to do a safety plan. And another just quick recommendation is we don't encourage providers to rely on these no suicide contracts. This was a lot more common in the 80s and 90s, where we would have, whether it was adults or teenagers, sign a contract essentially promising, I will not kill myself and I will attend my next appointment. The thought was that psychologically that might be a barrier. Next time they'll think, ooh, can't kill myself, I promised my doctor I wouldn't. But what we found is that is not super salient, and for many, especially teenagers, it feels a little coercive. It feels like you're being forced to sign this document as a condition for leaving the doctor's office and going home, and you might just be tired and sign the document. The other issue is that a no suicide contract doesn't tell me what to do. It just tells me I'm a bad person if I act on these thoughts. And so the reason we recommend a safety plan is it tells kids directly what we want them to do when they experience a crisis. It gives them a sense of what options are at my disposal when it feels like I have no options. Quickly, again, I want to spend a little time on non-suicidal self-injury. So this is direct, intentional destruction of one's own body tissue without the intent to die. So this doesn't include other intentional body modification procedures that are considered more socially sanctioned or appropriate. So even though a tattoo involves intentionally harming one's skin, that's often in many cultures considered more a way of self-expression. It's not a way of hurting yourself for the purpose of hurting yourself. But when we think of non-suicidal self-injury, these are things like cutting, whether it's one's wrists, thighs, other body parts, just self-cutting, burning, and it can include punching oneself or hitting one's head against the wall really hard. So with non-suicidal self-injury, what we found is it's actually more common in youth who are struggling with what we call dysregulation. So kids who have a lot of trouble managing really loud, intense emotions. This kind of intense behavior almost seems to fit better for those kids in quickly calming them down. Another thing that we know is that low family cohesion and high levels of family conflict really greatly increase the risk of non-suicidal self-injury. Again, think of a child who's overwhelmed and doesn't feel like they can comfortably or helpfully seek a parent for support in that moment. They can't cry on someone's shoulder. They might resort to these other methods in private. And then again, this is important, not just because it can create some medical complications if they engage in this behavior severely, but the more important piece of it is we know it increases one's risk of suicide, specifically suicide attempts by a pretty large margin, 5 to 10 times. So I also want to spend some time just myth busting why children engage in this behavior. I am often comparing it to something like substance use, where the reason that you are doing something that you might know is bad or harmful is because it's meeting an underlying need. A large majority of our patients experience this top left, where it quickly helps them regulate emotions that feel like they're out of control. It's a really intense sensation, and just biologically, this creates an intense response in the body that helps calm them down really quickly, even if that seems kind of counterintuitive to many of us. On the flip side, for patients who've been feeling significantly numb, they're experiencing trauma-related dissociation, where they feel like they don't even know where they are or whether they're dreaming. Sometimes that is a really uncomfortable feeling, and those patients will engage in self-harm just to feel something. So even the experience of intense pain really reminds them that they're alive. It helps kind of ground them in reality when they feel like they can't even place whether they're awake or asleep. Sometimes it's this bottom left one, where patients are engaging in this behavior specifically to punish themselves or as a way of saying that they deserve to be in pain out of some sort of self-hatred. This is not always the case, but certainly some of the time kids might feel like this is something that they have earned or deserve. I have this idea of self-validation. It might fit with the way that they view themselves pretty negatively. And then the last one that is a little less common but definitely happens is what we call interpersonal communication. So a really common misconception about this behavior is that kids are cutting themselves for attention, that they are doing this for the attention of their peers or for their parents. And there are some ways where this function can be a little bit related to that. I'd say the vast majority of kids are actively hiding their scars, actively hiding this, so it is more this emotion regulation mechanism. But for some children, they say, my mom doesn't take my depression seriously until she can see how serious it is. Or I might be told, hey, just think positive, have a glass of water, try to look on the bright side. But when they can see how significant my struggle is, then they think that I really need help. And so for some patients, it does serve this way of communicating what they're either unable to communicate verbally or what has been unsuccessfully communicated in the past. So based off of that, it's really important for us when we have a patient who engages in this behavior to figure out which of these purposes it's serving. Often it can serve more than one of these, so don't feel like it has to fit in just one box. For example, many patients will say it helps calm me down really fast, but other times I'm not even that overwhelmed, I just hate myself. So maybe 70% of the time one, 30% of the time the other. Because that tells us what interventions, what coping skills are going to be helpful. If I'm engaging in this behavior to communicate something to my mom, then an independent coping skill is not going to meet that need, right? I'm going to need a different strategy for communicating with my mom. So knowing the purpose helps us know how to solve it and address the underlying problem. So in terms of ongoing intervention, because these patients are more than just a safety plan, I really want to highlight that for some of these patients that screen positive, a good safety plan that we review every once in a while, we check in on, that'll be sufficient for many patients. Again, think of the patient who knows that they're overall at elevated risk, they had a suicide attempt 2 or 3 years ago, they've been in treatment, they feel really good. The safety plan might just be our backup plan that we make sure is still in good shape. But for many patients, they continue to experience ongoing suicidal thoughts and really struggling with these behaviors. And I think as providers, sometimes we feel stuck. We feel like I just have to keep reviewing and updating the safety plan. But really, the way that we treat suicidal thoughts is understanding what suicide is trying to solve. Again, very similar to the way we were thinking of the purposes of non-suicidal self-injury, we want to think of what purpose psychologically is thinking about suicide serving for these children. So I present a few common examples here of what quote-unquote problem suicide is trying to solve. You'll recall that I think of safety planning as essentially a problem-solving intervention. And this is addressing the fact that your brain will see sometimes suicide as the only option, and it might accurately have identified a problem, and we want to create additional options for them. So very, very common, again, especially in our teenagers, is number one, relieving immediate emotional stress. So if I am acutely overwhelmed, I feel like I can't do this anymore, I just can't take it, I just want this to be over, I'm sick of feeling this way. Many times that is the problem it's trying to solve. So we'll want to teach them some skills to resolve that safer and get them to the other side of what we know is likely to be a brief moment of pain. On number two, sometimes it's the broader pattern of I've been suffering for a long time, I've been dealing with depression for a long time, I have successfully survived a few moments of being overwhelmed, but I might take a longer perspective and think, this seems pointless, I'm worried I'm going to feel this way forever, I have only felt worse over the course of the last year or 2 years, there's no end in sight to this war, what is the point of all this, I'd rather just be done. So that is a slightly different kind of problem that we have to solve, is how do we demonstrate that the suffering will end and that ongoing pain would still be worth living through. Sometimes patients perceive themselves as a significant burden to those around them, whether that's their parents or caregivers. I worked with a patient who had previously engaged in a very medically severe suicide attempt that left them partially disabled. Involved a lot of care from their family, involved a lot of traumatic stress and grief from their family when they were in the hospital for an extended period of time. And then we were a little surprised a few months later to see this patient come back into our care for being really suicidal again. And when we asked, what is making you feel this way, what's making you have these thoughts, they identified that they know that they've created a lot of pain for their family, and they feel like, this is just going to be an ongoing path where now I'm disabled. I could make their lives easier if I were gone. Again, a painful thing to hear from a child, but a thing that a lot of kids and teenagers do think. And sometimes they have some evidence for, I'm creating some burden. They're not seeing that their families assess that burden to be worth it, and they would say, absolutely, we would rather you be here. But it is helping them kind of see the bigger picture there. And then again, this last one might be more of this shame-based or self-hatred, where I just think I deserve to die. I am a bad person. I don't deserve to be happy or be alive. So, kind of the 4 key things that we'll cover. We want to teach some skills to manage those emotions safely. We want to facilitate some family-based problem solving. We want to engage parents directly in continuing to do supervision, limit setting, and then we want to target directly those underlying, what we call drivers of suicidal urges. I'm going to go a little quickly through some of these slides just to cover the bigger principles rather than the nuts and bolts, but these slides will be available to you. So first is, why bother teaching skills? I think sometimes people want to get right to the heart of the pain, the beliefs that are making folks feel suicidal. And the reality is that skills are faster. They are easier to teach, and they might keep you, quote unquote, alive long enough to benefit from that deeper therapy that does take a little longer to sink in. We even know that many psychiatric medications take 4 to 6 weeks to have any impact, and that's if that medication is even a good fit. And so we want to make sure that behaviorally they have the tools to stay safe, stay alive through their next suicidal crisis, so that they're around to experience the benefits of the rest of therapy. Also, if I'm successfully coping with my feelings, I will feel better about myself. I'll feel like I have some amount of handle on my problems, and that also helps as a buffer. So which skills do we teach? Some of it is going to be some of that distraction-based coping, so helps take my mind off of the repetitive thoughts. But it's also going to be longer-term emotion regulation skills, helping them problem solve, helping them develop healthy habits that reduce their risk, reduce their vulnerability for a future crisis. I'm going to teach them how to communicate more effectively with others so I can get my needs met without having to be in an emotional crisis. And I'm also going to need to teach my patients to sit with their feelings. I think many of the children I work with are so afraid of letting themselves cry, so afraid of letting themselves feel anxious, because they've started to believe that the feelings themselves are dangerous. When the reality is, again, we know if they essentially ride out those feelings, it might take 10 to 30 minutes. It won't be comfortable, but it teaches their brain that you don't have to kill yourself just because you experience some amount of immediate distress. We're teaching them to exist with their own feelings. The family is really involved, again, in ongoing supervision. So we want to make sure that kids who we know are at risk of suicide, especially kids who still have some amount of intent or some openness to acting on their urges, we want to make sure that we're supervising them as much as possible. That doesn't mean they always need to be directly in eye contact, but it does mean we need to be really regularly checking in on them. We want to have parents support that problem solving, essentially being that outside regulation to help them generate ideas when they're not able to themselves. And a big focus is we want the family to use a calm voice, focus on the present moment during a crisis, so we're not saying, big picture, think of all of the harm that would be caused if you kill yourself. We're focusing on how do we solve the problem right now, using short sentences and really validating the emotions. So quickly, what does validation mean? That is acknowledging that the emotion that a patient is experiencing makes sense and is understandable. Now, I can validate the emotion and say that I understand it, I get it, I don't think they're crazy, and I can say all of that without agreeing with the behavior. So for instance, with self-harm, I can say, it makes sense that you were really overwhelmed, all of your friends were mad at you, and you got really scared and didn't know what to do. That makes sense. I can say that and not say, totally, I would have self-harmed in your shoes. There's nothing you could have done. I think that takes it a step too far, but we don't have to be afraid that we're unintentionally approving of the behavior just because we can understand it. I think many of our kids both understand that distinction and appreciate that you can understand their thought process and see their perspective. This also helps them label and understand their own emotions. Many youth really struggle to label their emotions accurately. They're good at saying, I felt good or I felt bad, I just wanted to do this, I don't know, I didn't think, I just did, and helping them slow down and recognize, no, you felt ashamed, you felt embarrassed. Getting to those really specific feelings words helps them understand more accurately what's happening, and it also helps them solve those problems better in the future. Also teaches them that they don't have to be afraid of those feelings. And then a big thing for families and caregivers that is always important to emphasize, we really don't want to treat self-harm or suicidal thoughts as a behavior problem or a disciplinary problem. I see many well-meaning families who treat this the same as, substance use or sneaking out. They say, if you cut yourself one more time, I'm taking your phone away, and I'm gonna check your body every day to make sure that you're not lying to me. And really that kind of misses the mark on what the point is here. What's actually happening is there's a deeper problem at play, and we want to do everything we can to support our kids in not feeling like they need to rely on this. Now, that doesn't mean that we are just passive and laid back and we let them have access to, let's say, sharp knives or razors. We can still, set limits and remove access to those tools, but we want to make sure that our response is not one of, I am disappointed in you, you were a bad kid, because that's likely to actually increase the likelihood that they'll do this again. What we want to do is say, I understand how you got there, but we need to find a new path forward. So I put back up the different reasons why a given person might engage in suicidal behavior or have thoughts of suicide. And I want us to start thinking about what are the drivers of suicide? What are the things that might push someone to that point? So a lot of times youth are not explicitly totally sure of why. They know that they're having the thoughts. They can give you sometimes a more general reason. I just feel really bad, or I felt really bad for a long time, or I miss my dad. But they struggle to narrow it down to the treatment relevant specific drivers. If you ask really broad questions like just, why do you want to die? They'll say, I don't know, or I just do, leave me alone. They might think you don't believe them. And so we want to help assess this in more detail so that we know, again, what specific interventions will be the most helpful. So for example, one that you might hear is, my PTSD makes me want to kill myself. It's so severe, I'm tired of waiting for it to get better. This might feel specific, right? But if my solution is engage in a 16-week PTSD treatment, I might be missing the very specific thing that'll reduce their suicide risk. Treating the PTSD is obviously a priority, but it's not quickly accomplished, so I want to narrow this down a little bit. So some other kind of candidate examples that might be more immediately targeted to really help increase their hope and increase their reasons for living. One could be that they're having really substantial nightmares. They don't feel safe at night, and that's really what takes this from being painful to being unbearable. So we can do 3 to 4 session nightmare protocol and really resolve that quickly, or even some psychiatric medications. They might just be having this deeper question of, what's the point of fighting to survive if life is full of pointless pain? even for this patient, if you fully treated their PTSD, we haven't necessarily addressed that question. And so we'd want to start there with doing some thought challenging, helping them explore the possibility that life is worth living, even with some amount of pain in it. And then they might be saying deep down, I feel like it's my fault that my parents were killed. I can't stop reliving those moments because I can't forgive myself. I deserve the punishment they got for my mistake. And so for this patient, it might be more specifically giving a lot of education around how many folks who experience trauma tend to blame themselves. That might mean that they're not actually at fault, but that their brain is having a normal reaction to an abnormal event. It also might be helping them see that their parents' death wasn't their fault, helping them re-examine that belief so that they arrive at something that is more related to healthy grief, where I'm sad that this happened, but I don't have to hate myself or kill myself because it happened. Again, when I'm looking for drivers, I want to start often with the most recent suicidal crisis. That will give me the most immediately relevant information, the most up-to-date information, rather than let's do a whole history of every time you've ever felt suicidal. That'll give me a lot of information, but not necessarily focused information. And then I don't want to make assumptions, right? I want to clarify what is the actual tipping point from painful emotions to these intense, more drastic urges. Again, on these examples, I saw that PTSD was a main piece of it, but if I had assumed that they were really terrorized by their nightmares rather than feeling really ashamed, I would again have missed the mark based on my assumptions of what about that problem is making them want to die. So I have a few example questions that I've found pretty helpful in terms of nailing down the details and helping just explore this non-judgmentally with a child. They, again, might not immediately know the answers to these questions, which is why we often start with an example and think of what came to mind at that moment that really kind of opened the door to suicide for you. So asking, what about this feels unbearable? If there's one thing that you could change, even if it's impossible, that would no longer make you suicidal, but even though you were still depressed, what would that one piece be? Those types of questions can be really illuminating in terms of recognizing what that key variable is for suicide specifically. And then when we start challenging suicidal thoughts, our goal is really to search for truth rather than to search for happy or positive thoughts. This is a really common mistake, especially earlier therapists make, where someone will say, life is just totally pointless, it'll never get better, and then we hit them with something overly positive in response, like, life is great, it's full of possibilities, anything can happen, and that doesn't work because it doesn't resonate and it doesn't ring true for the patient. The reason painful thoughts stick is because they feel truer even when they're not. And so being willing to dive into the deep end of these scarier thoughts with them really shows them that you're not just trying to make them feel better by lying to them, you're trying to find the most accurate picture of reality for them. Again, it can be helpful to just label distorted beliefs and say, hey, that's a really common symptom of depression. Here's 10 other depression patients who have had that exact thought. That might signal to them that it isn't that true because it's so commonly associated with a mental disorder. Oftentimes also behavioral experiments can be really powerful ways to learn that thoughts aren't true. So if I think, everybody in my life hates me and they'd be happier if I was gone, okay, so we're gonna stay home from school tomorrow. And then we're gonna see how did everyone react when you came back to school. Were they disappointed that you came back? No, they were excited to see you. They asked where you've been. And those direct experiments that challenge those thoughts sometimes can be more powerful, more memorable, and a little faster than kind of debating back and forth, especially when they think, well, it's your job to make me feel better. They just might not believe your perspective. And so when we do the direct reframing in therapy, we really want to guide them in clarifying, well, which of these thoughts is true? Rather than dictating to them, you shouldn't think this because this is what you're supposed to think. Again, it is more effective and it sticks better when they arrive at those conclusions with our support. So a real challenge when we're talking about armed conflict and war is that some of these really negative thoughts have at least a kernel of truth to them. And this is a little scary as a mental health provider, right? If someone is saying, I just don't see the point in this pointless war, it never ends, they're right. There's a real challenge to that in terms of supporting them without coming off as artificial. I think a lot of times we fear their thought, like what if that almost infects us? What if I start thinking about that? I might worry that I'm not very helpful if I just go, yeah, that's so hard, and I haven't fixed the problem that feels really hard as a provider. I might worry that any response comes off dismissive or tone deaf. If I try and help them see a positive side of something, is that rude or inconsiderate? I worry that if we talk about it all, make it worse because we're spending so much time on this thing that's so negative and so scary and so unfixable. And that's just hard. I'm used to challenging depression thoughts. I'm used to challenging really obviously untrue thoughts. And what do you do when the world comes into the room with them? Again, I think there's this tension between extremes that a lot of people struggle with, where on the one hand, we try and go overly positive. We try and really say, well, let's not think about that. That thought is scary. We might communicate that we're afraid of that thought and they should be terrified of that thought because it's too true and they can't handle it. So that's dangerous. But then on the other hand, I've seen some folks just fully pivot to acceptance. They're right. There's no hope. The world is full of pain and suffering. And honestly, I can't fix any of the problems they're coming in with, so there's nothing I can do other than give them a happy, comfortable session. And that's not fair either. They're coming to you with significant challenges, and it's our task to find the hope for them when they're not able to. So I really want to recommend this new path forward for these difficult thoughts that have at least some amount of painful truth to them. First, we can challenge kind of other thoughts around that truth, right? If I am experiencing a lot of pain because of, the war is really disturbing me, I might learn, what about the war disturbs you? Well, it shows me that all people are fundamentally evil and this world is a horrible, evil place. That second thought I can challenge, right? I can find examples of goodness in the heart of people around me. And so I don't have to challenge the first thought that there is evil in the world, but I can challenge this other thought that's actually creating more problems. It's important to validate and practice accepting things that are hard truths, right? I don't have to fight and spend my emotional energy saying it shouldn't be this way, it shouldn't have to happen. You're right, so how do we move forward? Because continuing to say it shouldn't be this way isn't making me feel better and it's not solving the problem. And then ultimately we want to find ways to move forward and live a life that's consistent with my own values. How can I move forward even in a world that's full of senseless suffering? How can I find ways to live a life that feels like I am proud of? So I'm going to end on an example just to illustrate all of these other ongoing interventions. So Mikola is a 15-year-old boy referred for therapy by his primary care physician after he shared some thoughts about hurting and killing himself. Mikola denies that he wants to die right now, which is great, but he reports having had these thoughts and continuing to experience these thoughts when he thinks about his father who was killed in the war. He misses his father, and he's really struggled to accept his death because it was part of a pointless war. This has led to him thinking a lot about the suffering that takes place throughout the world, how much of it is pointless, leading to him believing that, quote, life is full of meaningless pain. These thoughts really scare him, so he spends a lot of his time trying to avoid these thoughts and avoiding any reminders of his father. This is creating a lot of pain in his household because he's, spending a lot less time with the family as a way of avoiding these painful feelings. So, hard situation, but there are a lot of things that we have to offer to Mikola. First of all, we want to start with the basics. We want to engage his guardians. Let's say in this case, it's his grandparents who are taking care of him, in doing some planning and monitoring. We do want to make them aware that he's been having these thoughts, but we don't want to scare them and say you have to lock him in the house 24 hours a day. We want to make sure he still has access to things that make life worth living, including that teenage desire for a little bit of freedom. But we want to make sure that any firearms in the house are securely stored and stored away from where he can access them. This might be a situation where just based on the area they live in, they're not comfortable fully getting rid of their firearm, and that's okay. We work with them on ways to store it in a safe, and specifically with grandfather on some different ways to safely store the firearm with a specific lock. Then we do some safety planning with Mikola. We want to remind him of his reasons for living, and he wants to stay alive for his grandparents and for his little sister. He saw how much it impacted them to lose his father, and he wants to make sure that he's around to be there for them, as well as to be a role model to his younger sister. That motivation is going to go a long way in these darker moments for him. We want him to learn some relaxation exercises so that before bed he isn't just stewing in these thoughts that he's been avoiding all day. And we want him to have some kind of code words for communicating with his grandparents. They're not as familiar with mental health, so they do get a little anxious and a little unsettled if he just says, "I'm thinking of killing myself." So they decide on the term, "I'm feeling unsafe." And that, for them, communicates, you need some other supervision. You need us to stay with you for right now. We'll spend some time teaching him other ways to tolerate distress in the moment. He clearly needs to learn some amount of being with his emotions and not being afraid of experiencing that grief that he's been hiding from and avoiding. And some of that will look like acceptance of some of the painful realities of this world, that people are dying for senseless and pointless reasons, and that's not fair. And accepting that for what it is, rather than trying to put a happy spin on it or railing against it, is really what's going to get him farther. And then ongoing, we're probably going to need to do some interventions for traumatic grief. It seems like he is having a more complicated grief response, really struggling with, missing his father, feeling like that represents something really negative about the world, when in reality, he can kind of start reframing that in terms of, how do I honor my father's life and carry pieces of him with me everywhere I go? We want to challenge some of his earlier thoughts about how life is pointless if it's full of pain, and really help him see examples of, even with pain, life can be really meaningful and really worthwhile. And then again, we will want to intentionally plan for him to engage in some behaviors on a regular basis that establish this meaningful life. Lives don't get meaningful just by talking about it, and so really making sure intentionally with him, even if you have a really productive hour, you are giving him tasks to do that help him feel aligned with what makes life important and meaningful. So in summary, patients need skills. They need care that is focused on their specific drivers of suicide. And we need to identify those critical links between the things that cause them stress and the behaviors that create danger or risk for them. And that's all I have for today. So thank you guys.